Welcome to this video on cephalosporins. In this video, we'll discuss about Cefepime and Ceftaroline, which are the fourth and fifth generation of cephalosporins. If you're new to this channel, do subscribe. We have discussed all the antibiotics series, and this is last but not the final video of this antibiotic series. After this video, I think you'll be much more confident in prescribing an antibiotic to a patient with knowing in-depth content and knowledge about each and every antibiotic. So let's get started. So this big picture and mechanism of cefepime and ceftaroline. The cefepime is a fourth generation cephalosporin. It is an ICU empiric workhorse, not commonly used in India, but it is a very good antibiotic with gram-negative coverage plus Pseudomonas coverage, also for AmpC coverage. So when you suspect an organism with AmpC, that is spices organism, you can always use Cefepime. So if you're not known about this spices organism, we have already discussed this in the video on approach to antibiotics module 3 and 4. Do watch it for better understanding of AMCs. These spices organisms are Serratia, protease, indole positive organisms, then Enterococcus cloacae. So ceftaroline is an only cephalosporin drug with reliable MRSA coverage. That is the only better advantage of ceftaroline. Otherwise, it is other things are the common things. So cefepime is also can be used for AMC producers, but not for ESBL organisms. For ESBL organisms, it is better to go for carbapenems. So mechanism of action, it does again the beta-lactam drugs binds to penicillin binding proteins, inhibits cell wall synthesis. It is a time-dependent killing mechanism that similar to all other cephalosporins. If you want to know much about this, do watch the cephalosporin module 1. So teaching pearls, that is the success depends on the dose, infusion strategy, and the renal function. So how you give, in what dose, and the how long you give as an infusion, and the renal function of the patient determines the final outcome of these antibiotics. So cefepime means absolute contraindications are only to allergy to most third generation cephalosporins have the same side chain group to cefepime also. So try to avoid it during allergy to cefepime. So relative or active seizures, delirium and CNS infection. This you have to remember that cefepime is a very neurologically toxic drug. It reduces the seizure threshold. It can cause acute delirium and in cases of active CNS disease, try to avoid cefepime. Interaction has very minimal interactions, no significant cytochrome inhibition or induction. Massive advantage in polypharmacy in ICU patients is because of this indication. So CNS toxicity is the most important side effect that you must need to know. It can present with myoclonus, delirium, seizures, and non-convulsive status epilepticus. So always keep this in mind and try to avoid amplifying in case of CNS dysfunction. So sepsis associated encephalopathy can also be very close mimicker of this cefepime-induced neurotoxicity. Always review the medication list in ICU patients. So in a confused patient getting cefepime, try to change it to another antibiotic. Neurotoxicity is especially seen in elderly patients, renal dysfunction due to dose accumulation, history of past seizures, and pre-existing brain injuries. So neurotoxicity can occur even with renal adjusted doses, so be aware of that. So cefepime side effects are mainly drug fever. It can lead to hematological manifestations, although rare, can cause positive Coombs reaction and autoimmune hemolysis with neutropenia and thrombocytopenia. All three cell lines could be affected. So it can lead to high Clostridium difficile risk than Piperacillin tazobactam. Why it is compared with Piperacillin tazobactam is because both these cover Pseudomonas, whereas cefepime can cover against AmpC spectrum of organisms, where Piperacillin tazobactam cannot. Piperacillin tazobactam is a BLBLA group of drug. This comes under fourth generation cephalosporin. Cefepime also has some gram-positive coverage. It does not cover Enterococcus. Can be given for MRSA, Staph saprophyticus, most coagulation-active Staphylococcus, non-Enterococcus streptococci, and Streptococcus pneumonia also. So this is having a good amount of gram-positive spectrum, but not for Enterococcus. So for gram-negative spectrum, Pseudomonas aeruginosa, excellent interbacterial coverage, AmpC-inducible organisms, then it's the spices organisms, and even for Acinetobacter species, the cefepime can be used. Haemophilus influenza and Neisseria meningitis also, cefepime can be used. It is superior to ceftriaxone and ceftazidime for AmpC organisms. That is the most important thing that you need to remember. So if your cefepime is not available, yes, anyways, you can go for carbapenem drug. So Cefepime clinical use is mainly community-acquired septic shock, febrile neutropenia, and hospital-acquired pneumonia. So it specifically targets bacteremia, intra-abdominal infection, CNS infections, and suspected AmpC producers. These are the main indications you use Cefepime for. This is Pip-Tazo in Tazobactam. So prefer Pip-Taz when you need an anaerobic coverage or you need a lower neurotoxicity risk. So Pip-Taz is a better drug compared to Cefepime in these aspects. And use Cefepime in the concern of AmpC organisms in case of severe sepsis septic shock and for the need for stronger gram-negative activity. So standard dosing is 2 gram IV Q 12 hourly, that is twice a day dosing for J for more than 50. High dose can be given few gram IV Q 8 hourly in case of Pseudomonas, CNS infection, morbid obesity, febrile neutropenia, and AmpC organisms with augmented renal clearance. So infusion strategy is again for most of the cephalosporin group of drugs, carbapenems, Brazil and tazobactam. We advise an extended infusion over 3 hour strategy. Why? Because it improves the time in range more than the minimum inhibitory concentration. It is best used for augmented renal clearance patients and high MIC pathogens. It is underused, but it's a highly effective ICU strategy. Extended infusion time. So renal adjustment, when the GFR is less than 50, you can still go with Q12 hourly dose or Q24 hourly dose. Less than 30, go for Q once a day dosing. GFR is less than 11, this 1 gram Q24 hourly. For CRRT patients, 1 gram Q8 hourly, obesity up to 2 gram IV Q8 hourly with extended infusion. In case of ECMO, there is no need to adjust the dose. Pharmacologically, it is a 480 gram molecule with protein binding of only 20%. It has a good CNS penetration with low volume of distribution. Can go into inflamed meninges also. So 85% is renal unchanged. Half-life is 2 hours, up to 13 to 18 hours in even in dialysis. Ceftaroline contraindications. Coming to ceftaroline, it is only for allergic to ceftaroline patients. You need to stop giving this drug. It has a very minimal drug-drug interaction as similar to cefepime. Side effects are again nausea, diarrhea, rash, and clostridium difficile infection. Serious side effects can occur, but rarely, such as neutropenia. And neurological toxicity, again, seizure and encephalopathy can occur, especially in renal dysfunction patients. It is mainly a gram-positive workhorse. It is also considered the gram-positive hero. It covers MRSA. That is the most major advantage of this group of drug. It can also cover MSSA, and cons, vancomycin, intermediate Acinetobacters, Streptococcus pneumonia, Group A, Group B Streptococcus, Enterococcus fecalis. So it is the only cephalosporin with reliable MRSA activity. Ceftaroline gram-negative spectrum, it misses the most organisms, so it is not cannot be given for ESBL organism. It is the most important like disadvantage of this group of drug. It is hydrolyzed by AmpC group of organisms also, so it cannot be given for AmpC producers. Cannot be given for Pseudomonas. So in these cases, Cefepime gets the heads up. So similar to ceftriaxone, it covers E. coli, Klebsiella, and Proteus. Clinical uses can be used mainly for skin and soft tissue infection, pneumonia, and empiric regimens needing MRSA coverage. So, salvage therapy can be used for salvage therapy in MRSA bacteremia and endocarditis, often used when vancomycin is failed, daptomycin is failed. So, salvage strategy for the MRSA is ceftaroline plus daptomycin. With the synergy mechanism, ceftaroline improves daptomycin binding. It clears refractory MRSA bacteremia. That is a major thing that you need to know as a salvage therapy for MRSA. So ceftaroline standard dosing is 600 mg Q12 hourly. High dose can be given Q8 hourly for endocarditis, MRSA bacteremia with MIC of 2 to 4 and augmented renal clearance patient. Renal dosing is adjusted accordingly. In case of GFR less than 30, it is 400 mg Q12 hourly. If GFR is less than 50 or on HD, it is 300 mg to 200 mg Q12 hourly. It is a molecular weight is high compared to cefepime with 20% protein binding with low volume of distribution. Only 10% is CNS penetration. 75% is exceeded unchanged in the urine with a half-life of only 2.5 hours. So head-to-head comparison for MRSA, you can go for cefepime, ceftaroline. In case of Pseudomonas, you can go for cefepime. AmpC, you can go for cefepime. ICU empiric therapy, you can go for cefepime. For MRSA coverage, always go for ceftaroline. So only for MRSA coverage, nowadays we use that is even for salvage therapy. We use ceftaroline. Otherwise, there are better drugs available in this group of classes as well as other group classes. Final take home message, ceftaroline is a MRSA focused drug, excellent salvage agent. So Cefepime is an gram-negative ICU backbone, can be used if other you need an AmpC coverage or an higher gram-negative coverage. The main important adverse effect of this is neurotoxicity, which needs to be monitored. So these drugs are complements having different uses, and they are not competitors. They're just a different generation of cephalosporin with a different spectrum of activity. Hope you learned a lot in this video on antibiotic series. This is Medicine Beyond Harrison's. Do like and subscribe. Thank you for watching.